Welcome to the Deep Dive. Today we're taking a truly fascinating deep dive into something that impacts, well, every single one of us, every minute of every day, your blood pressure.
That's right.
We've got a stack of key sources, research or notes, and our mission, like always, is to cut through the noise, pull out the really important insights, and maybe uncover some surprising facts and, practical knowledge you can actually use.
Exactly. It's such a fundamental measure of health, but surprisingly complex when you dig in.
Yeah.
So to make it clear, we're really focusing on the two main poles here. Hypertension, that's high blood pressure, and then hypotension, which is low blood pressure.
Right.
Our goal is pretty straightforward. Turn what can feel like overwhelming medical jargon into genuinely clear, understandable, and, well, useful knowledge for you.
Because blood pressure, it's a phrase we all hear, right? But the nuances, the surprising ways it connects to your overall well-being, the everyday implications, they're truly remarkable. So let's jump in. Okay, let's unpack this. Starting with hypertension, often called the silent threat. What exactly is blood pressure? How do we even measure it? We hear systolic, diastolic. What do those numbers mean?
Great place to start. So blood pressure is basically the force. It's your blood pushing against the artery walls as your heart pumps it around. We measure it in millimeters of mercury, MAHg,
Okay.
and you get two numbers. The first one, the top number, that's systolic pressure. That's the peak pressure when your heart actually beats, pushing blood out.
Got it.
The second one, the bottom number, is diastolic. That's the pressure in your arteries when your heart is resting, between beats.
Right, the lower number.
Knowing these numbers is really key. So generally, normal blood pressure, we consider that less than 120 systolic A&D, less than 80 diastolic, so under 120 over 80.
Like standard target.
Then if that top number, the systolic, creeps up to between 120 and 129, but the bottom one, diastolic, is still under 80, that's called elevated blood pressure.
Ah, like a warning sign.
Exactly. It's like a yellow light. It signals that, hey, some lifestyle changes are probably needed to stop it going higher. Then you get into hypertension. Stage 1 is generally a 130 to 139 systolic OR, 80 to 89 diastolic. Stage 2 is a 140 or higher systolic or 90 or higher diastolic.
So even if just one number is high, that counts.
That's right, either the top or the bottom number being in those ranges. And crucially, this isn't usually based on just one reading. For diagnosis, these elevated readings generally need to be confirmed on at least two different readings taken on at least two separate visits.
That makes sense, avoids a one-off spike.
Yeah.
So why does high blood pressure happen? Is there always a clear reason?
That's a huge question. And here's where it gets, well, really interesting. For most people, the vast majority, in fact, the exact cause is a bit of a mystery. Yeah. About 95% of cases are what we call primary or essential hypertension.
Yeah.
That means there's no single identifiable underlying medical condition causing it.
95%. Wow.
It's huge.
Yeah.
We know it's often linked to things like how your body handles salt, maybe increased activity in the nervous system, certain hormonal factors. But there isn't one thing you can point to and fix. Just is. Hence, essential.
Okay, so that's primary. What about the other 5%?
Right. That remaining 5% is secondary hypertension. And this is important because here, there's an underlying cause, and often it's something treatable.
Okay. Like what?
Things like specific kidney problems, renovascular disease is actually the most common secondary cause, or certain hormone imbalances like problems with the adrenal glands, Cushing's syndrome, things like that. Even conditions like severe sleep apnea or sometimes medications, or even heavy alcohol use can be the culprit.
So finding that cause could potentially fix the blood pressure issue itself.
Precisely. If you treat the root cause, the secondary hypertension can often resolve. That's why doctors investigate, especially if the hypertension appears suddenly or is hard to control.
Okay, so that 95%, primary hypertension. What's the big deal then if it stays high? It might not feel bad, right? That's why it gets called the silent killer. What are the actual risks?
That nickname, silent killer, is spot on. You often don't feel symptoms until, well, significant damage has already started happening inside. Uncontrolled high blood pressure puts constant stress on your blood vessels, your heart, your kidneys, your brain, pretty much everything.
Okay.
Over time, this widespread damage can affect nearly every major system. For your heart and blood vessels, it dramatically bumps up the risk of coronary artery disease, heart attacks, heart failure, even left ventricular hypertrophy that's thickening of the heart muscle. It can also weaken arteries, leading to aneurysms, those dangerous bulges.
That's right, like a weak spot in a tire.
Exactly. And your brain is definitely vulnerable too. Higher risk of strokes, both ischemic and hemorrhagic, TIAs or mini strokes, and even a kind of brain dysfunction called encephalopathy.
And kidneys. You mentioned kidney disease earlier.
Yes, critically, high blood pressure is a major driver of kidney damage, what we call nephropathy. In fact, it's the second most common cause of end-stage kidney disease requiring dialysis or transplant in the U.S. Only diabetes causes more.
Second most common. That's huge.
It really is. And it doesn't stop there. Your eyes can be affected too. It can damage the tiny, delicate blood vessels in the retina at the back of your eye, leading to vision problems, even blindness in severe cases, retinopathy.
So it really is a systemic issue, head to toe.
Absolutely.
Before getting to treatment then, how do doctors figure all this out? If someone comes in with high readings, what's involved in the workup?
It's a pretty comprehensive process, aiming to get the full picture. It starts, naturally, with a thorough physical exam. And part of that might involve the doctor looking into the back of your eye with an ophthalmoscope, that's fundoscopy, checking for those retinal vessel changes we just mentioned.
Seeing the damage directly.
Yeah, it can be an early sign. Then comes the lab work. Blood tests are crucial, checking kidney function, things like creatinine and electrolytes, sodium, potassium, calcium. Also a urinalysis, looking for protein or albumin in the urine, another sign of kidney stress.
Okay.
They'll also likely check things often linked to blood pressure, like fasting blood sugar for diabetes risk, cholesterol levels and a lipid profile, maybe thyroid function with a TSH test, and a complete blood count, a CBC.
So checking for related conditions or complications.
Exactly. And cardiac tests are important too. An ECG, or electrocardiogram, is standard. It checks the heart's electrical activity and can show signs if the heart muscle, particularly the left ventricle, has thickened from working against high pressure, that left ventricular hypertrophy again. Sometimes an echocardiogram, an ultrasound of the heart, might be done too.
Okay, so a pretty thorough investigation. Once all that info is gathered, what does it actually mean for managing hypertension? Is it straight to pills or?
Oh, not usually straight to pills, unless the pressure is very high or there are other significant risks. Actually, the initial management, the foundation, really is lifestyle changes.
Right, the things we can control ourselves.
Absolutely. And these can be incredibly powerful. We're talking about adopting habits that genuinely reduce the strain on your heart and blood vessels.
Like what specifically?
Well, weight loss is a big one if you're overweight. Aiming for a healthy body mass index, say between 18.5 and 24.9, even modest weight loss makes a difference. Losing just 10 kilograms, about 22 pounds, can potentially lower your blood pressure by a significant 5 to 20 millimilli HT.
Wow, that's substantial.
It is. Regular exercise, aiming for at least 30 minutes most days of the week. Quitting smoking, that's just non-negotiable for heart health overall. Then diet. The DDECA's dietary approaches to stop hypertension is heavily recommended.
What does that involve?
It's rich in fruits, vegetables, whole grains, lean protein, low-fat dairy. And importantly, it's low in saturated and total fats, and especially low in sodium, aiming for less than 2.4 grams a day, which is about a teaspoon of salt.
So cutting back on salt is key.
Definitely. Also, boosting dietary intake of potassium, calcium, and magnesium seems to help lower blood pressure. And finally, moderating alcohol intake, generally no more than 2 standard drinks per day for men and 1 per day for women.
Okay, so a lot of lifestyle factors. What's the goal then, the target blood pressure?
The general target for most adults is usually aiming for less than 490 millimilli HG. It might be slightly higher, like less than 50/90/90, for adults age 60 or older, though guidelines can vary a bit. But achieving these targets, the benefits are profound.
How profound?
We're talking about potentially cutting your risk of developing heart failure by 50%, strokes by around 40%, heart attacks by 20 to 25%. It's truly life-saving and life-changing.
Those numbers are really compelling. So what happens if someone tries these lifestyle changes, really gives them a go, but their blood pressure is still too high? That's when medication enters the picture.
Precisely. If lifestyle modifications alone don't get the blood pressure down to the target range after a reasonable trial, then medication becomes a really important tool. And the good news is, we have many effective options now.
Okay. So how do doctors choose? Is there a standard first-line drug?
There are several common initial choices for what we call uncomplicated hypertension, meaning high blood pressure without certain specific other conditions. These often include thiazide-type diuretics, the water pills that help reduce fluid volume, ACE inhibitors, or ARBs, angiotensin II, receptor blockers. These work on the renin-angiotensin system to relax blood vessels. Calcium channel blockers, which also help relax blood vessels and sometimes slow the heart rate, and sometimes beta blockers, which primarily slow the heart rate and reduce its force.
So several main classes, but you mentioned uncomplicated. Does the choice change if someone does have other health issues?
Absolutely. This is where treatment becomes really tailored. The presence of coexisting conditions is a major factor in choosing the best medication or combination of medications.
Can you give some examples?
Sure. For instance, if someone has angina chest pain from heart disease, a beta blocker or a calcium channel blocker might be preferred. After a heart attack, an ACE inhibitor or a beta blocker is usually strongly recommended.
Okay.
If someone has heart failure, particularly with reduced pumping function, then ACE inhibitors, ARBs, beta blockers, and specific diuretics are key parts of therapy. For people with diabetes or chronic kidney disease, ACE inhibitors or ARBs are often first-line choices because they offer extra protection for the kidneys.
Ah, so it protects the kidneys and lowers blood pressure.
Exactly, a double benefit. Other examples. Older adults with isolated systolic hypertension, just the top number is high, often respond well to diuretics or calcium channel blockers. If someone has osteoporosis, a thiazide diuretic might be a good pick because it actually helps reduce calcium loss in the urine.
Interesting.
For men with an enlarged prostate BPH, an alpha blocker might help both conditions.
Yeah.
There are even considerations based on ethnicity or age, for example. Black or African American patients often respond particularly well initially to thiazides or calcium channel blockers.
Yeah.
Younger Caucasian males might start with thiazides, ACEs, or ARBs.
It sounds incredibly personalized.
It really has to be. Even conditions like gout matter. Most diuretics can worsen gout, but calcium channel blockers are okay. And one specific ARB, losartan, actually helps lower uric acid. Or if someone has atrial fibrillation, beta blockers or certain calcium channel blockers help control heart rate. Raynaud's phenomenon. Specific calcium channel blockers can help. Even things like migraines or essential tremor can guide choices towards beta blockers like propranolol.
Wow, so many factors to weigh. Are there also drugs to actively avoid with certain conditions?
Yes, definitely. That's just as important. For example, you'd use beta blockers or certain older drugs like central alpha-2 agonists cautiously in someone with depression. Thiazide and loop diuretics can worsen gout, as we mentioned. ACE inhibitors and ARBs need caution if someone already has high potassium levels or severe kidney artery stenosis. Beta blockers and certain calcium channel blockers are generally avoided in people with significant heart blocks, and ACE inhibitors are a no-go if someone has had angioedema, that serious swelling reaction.
Right, so it's a complex balancing act.
It is. It's about maximizing benefit while minimizing risk based on the individual's entire health profile.
Okay, that covers chronic management really well. Now, shifting gears a bit,
Yeah.
let's talk about those scary acute situations. Extremely high blood pressure. You mentioned earlier there's a critical difference between an urgency and an emergency. Can you break that down?
Yes, this distinction is absolutely crucial because it dictates how quickly and aggressively the blood pressure needs to be lowered. Both involve very high readings, let's say systolic over 180 or diastolic over 120, really high.
Okay, seriously elevated.
Right. Now, if the blood pressure is that high, BUT, there's no evidence of acute ongoing damage to major organs. The brain, heart, kidneys, eyes, that's classified as hypertensive urgency.
So, high numbers, maybe some symptoms, but the organs seem okay for now.
Exactly. The person might have a severe headache, maybe feel short of breath, or have some chest pain, perhaps some neurologic fuzziness. But crucially, diagnostic tests don't show immediate acute organ injury like a stroke or heart attack happening right now.
So, what's the approach then?
The goal here is gradual reduction. You want to lower the mean arterial pressure that's sort of an average pressure by no more than about 25–30% over the first few hours, maybe aiming for a target like less than 160 over 100 millimole Hg initially. Dropping it too fast can actually be harmful, potentially reducing blood flow to vital organs too much. This is usually managed with oral medications like clonidine or captopril, sometimes levodopa.
Okay, urgency means high numbers, lower it carefully, usually with oral meds. What makes it an emergency?
Hypertensive emergency is when you have those same extremely high numbers, over 180 systolic or over 120 diastolic A and D. There's clear evidence of acute ongoing end organ damage. This is a true medical crisis.
Okay, so the damage is happening right now. What kind of damage?
It could be neurologic, hypertensive encephalopathy, which is brain swelling, an active stroke, whether ischemic or hemorrhagic, or seizures, cardiac damage, the acute coronary syndrome like a heart attack, acute heart failure perhaps with fluid in the lungs, pulmonary edema, or even an aortic dissection that tear the main artery.
Aortic dissection sounds terrifying.
It is extremely serious. Renal damage, acute kidney injury with signs like protein or blood in the urine, or retinal damage. severe grade IV retinopathy, sometimes called malignant hypertension, visible in the eyes.
So if any of those are happening alongside the super high BP, it's an emergency.
Precisely. And this situation demands immediate action, usually in an ICU setting, with intravenous blood pressure lowering medications. The goal is still generally a gradual reduction, maybe lowering the MAP by about 10–20% in the first hour and another 5–15% over the next 23 hours, but it requires IV meds for tighter control.
Are there exceptions where you do lower it fast?
Yes, a few critical ones. For acute aortic dissection, you need to lower the systolic pressure rapidly, often down to a target of 120 millimilli Hg within about 20 minutes to reduce the shearing force on the aorta wall.
Okay, that's one major exception. Any others?
Another key one involves acute ischemic stroke. Here, doctors are usually very cautious about lowering BP unless it's extremely high, like over 1,850/110 if the patient might get clot-busting drugs, or over 2120 if they're not a candidate for thrombolytics. The brain might need that higher pressure to perfuse the damaged area. So often, mild to moderate high BP is tolerated initially in ischemic stroke. How you manage pressure with bleeding in the brain, intracerebral hemorrhage, is also complex and depends on various factors.
Wow. So really specific protocols for different emergencies.
Absolutely. And the choice of IG drug depends on the specific emergency too. For example, labetalol or nicardipine might be used for neurologic emergencies, while esmolol or labetalol plus maybe sodium metroprusside are key for aortic dissection, and nitroglycerin or furosemide for acute heart failure with pulmonary edema.
Okay, that urgency versus emergency distinction is incredibly clear and obviously vital. Now let's flip the coin entirely. Let's pivot to the opposite problem. Low blood pressure or hypotension. This might seem less serious than high pressure, but it can cause real problems too, right? Dizziness, falls, fainting.
Absolutely. Low blood pressure can be incredibly disruptive and sometimes dangerous, especially concerning falls in older adults. One very common type is postural hypotension, also called orthostatic hypotension.
Orthostatic, meaning related to posture.
Exactly. It's defined by a significant drop in blood pressure when you stand up. Specifically, a fall of at least 20 millimilli Hg in systolic pressure, or at least 10 millimilli Hg in diastolic pressure, or both, usually within about 2 to 5 minutes of standing quietly after lying down or sitting.
It's 20 systolic or 10 diastolic drop just from standing up. Why does it happen?
It's often due to either impaired function of the autonomic nervous system, the system that automatically regulates things like blood pressure, or simply decreased blood volume, or sometimes a combination. It's particularly common in people over 65.
What are the common triggers or causes?
Medications are a big one.
Oh.
Antihypertensives themselves, especially things like alpha blockers or nitrates, but also diuretics, narcotics, some antipsychotics or antidepressants, even alcohol.
So the treatment for high BP can sometimes cause low BP.
It can. Yeah, it's a balancing act. Other causes include neurologic conditions that affect autonomic nerves, like diabetic neuropathy, Parkinson's disease, or other polyneuropathies, and simply being low on volume hypovolemia from things like dehydration, hemorrhage, severe vomiting, or overdiuresis.
Okay. And the symptoms, what does it feel like?
It's mostly due to reduced blood flow to the brain, cerebral hypoperfusion. So people feel dizzy, lightheaded, maybe their vision blurs or darkens, they might feel palpitations, and in some cases, they can actually faint, which we call syncope.
How do doctors check for this?
The first step is usually measuring orthostatic vital signs, checking the blood pressure and heart rate while the person is lying down, then after sitting, and then after standing for a few minutes, looking for that characteristic drop. If those aren't conclusive but symptoms are suggestive, a tilt table test might be done.
Tilt table.
Yeah, they strap you safely to a table that can be tilted upright to simulate standing while monitoring your BP and heart rate continuously. Lab tests like checking blood count for anemia or electrolytes and kidney function for dehydration can also help identify underlying causes.
Right. So how is orthostatic hypotension managed?
Often starts with conservative non-drug measures. First, address any reversible causes, like adjusting medications if possible. Then, simple things like increasing salt and fluid intake to boost blood volume unless there's a reason not to, like heart failure.
So more salt and water.
Often, yes. Also advising people to change positions, gradually rise slowly from bed or a chair. Wearing compression stockings or even abdominal binders can help push blood back up from the legs. Regular exercise can improve vascular tone. Even small things like elevating the head of the bed 30–45 degrees while sleeping can sometimes help reduce morning symptoms.
What if those steps aren't enough?
Then medical management comes in. The first-line medication is often fludrocortisone. It's a synthetic mineralocorticoid that helps the body retain salt and water expanding blood volume and increasing vascular tone.
Does it have side effects?
It can. Potential side effects include low potassium, swelling or edema, potentially worsening heart failure, and sometimes making blood pressure too high when seated or lying down. So it requires monitoring. Other options include pressor agents like midodrine, which directly constricts blood vessels, or droxidopa, which gets converted to norepinephrine fluid in the body.
Okay, so options exist if the simple measures fail. Now, beyond just standing up causing issues, what about fainting that seems to come out of nowhere? Sudden, temporary drops in blood pressure.
Right, that brings us to another major category, reflex-mediated syncope, sometimes called neural-mediated syncope. This is basically fainting caused by a temporary glitch or overreaction in the nervous system, signals that control heart rate and blood pressure.
A nervous system glitch.
Sort of. The most common type by far, especially in people without known heart or neurological disease, is vasovagal syncope. You might have heard it called a simple faint.
Vasovagal. I think I have. What triggers that?
It's often triggered by specific situations. Things like the sight of blood phobia, intense emotional stress or fear, pain, trauma, sometimes even prolonged standing in a warm place.
Yeah.
Your body basically overreacts.
How does it manifest? Do people just drop?
Often, there's a warning phase, what doctors call a prodrome. Before fainting, the person might feel dizzy, lightheaded, maybe nauseous or have stomach discomfort. They might get pale, sweaty, feel warm, have blurred or tunnel vision, maybe palpitations. It's the body signaling something's off. Then comes the brief loss of consciousness, the syncope, followed usually by a quick recovery, maybe feeling a bit groggy afterwards.
So there are usually warning signs. Are there other types of this reflex fainting?
Yes, there's carotid sinus syncope. This happens when there's minor stimulation to a sensitive area in the neck where the carotid artery is, called the carotid sinus. Things like shaving over that area, wearing a tight collar, or even just turning the head sharply can trigger it in susceptible people.
Wow, just turning your head.
It can happen. And then there's situational syncope. Here, the trigger is a specific bodily action or situation. Common ones include straining during defecation or urination, micturition, forceful coughing or sneezing fits, sometimes even after eating a large meal, postprandial syncope.
So lots of different potential triggers for these reflex faints.
Indeed. It's all about the nervous system, temporarily losing its grip on blood pressure regulation in response to a specific trigger.
Wow, what an incredible deep dive. We've really covered the spectrum, haven't we? From the chronic, quiet threat of hypertension, understanding the numbers, the primary versus secondary causes, the widespread damage it can do.
Right, and the crucial lifestyle changes, and then the very tailored medication approaches.
Exactly. Then moving to those acute hypertensive crises, understanding that absolutely. Well, thank you for joining us on this deep dive into the world of blood pressure. We really hope this new understanding gives you maybe a different perspective, helps you think differently about your own health and choices. So here's a final thought to leave you with. How might understanding this intricate dance of blood pressure regulation change how you think about everyday things? Your morning coffee, maybe a stressful meeting at work, the importance of hydration, or even just the simple act of standing up too quickly? What small awareness, what tiny change could potentially make a big difference down the road for your own vascular health? Something to ponder. We'll see you next time on The Deep Dive.